We have some minutes left for other questions. I have one question left for Professor Prete, and I don't know, I'm not sure if it's see it again. There's one question, is renin activity interfered?
So, thanks for the question. So the plasma renin activity is a bit of a weird test in a way. So the technical aspect of measuring plasma renin activity can be quite challenging for the lab. So this is the reason why I said before that it's increasingly less used in clinical practice. However, one thing that I can say is that if you are measuring plasma, so between plasma renin activity and direct renin concentration, that is not really a difference, or in terms of screening for primary aldosteronism. There is, however, one thing that we should take into consideration, which is people who use aliskiren, which is the direct renin inhibitor. Okay. I didn't mention this in the talk because it's not a medication that is commonly used, but some centers use it to treat hypertension. So you need to be very careful if the patient is taking aliskiren, because this will have a different effect on renin depending on the assay that you're using. Because of the way it works, if you're using a direct renin inhibitor, if you're measuring plasma renin activity, then the aliskiren will lower the renin activity in the blood. So meaning that it's more likely to cause a false positive result. However, if the patient is taking aliskiren and you're using direct renin concentrations, is the opposite. Because you're blocking the activity, so by negative feedback, the production of renin will increase. So if you're using the direct renin concentrations, aliskiren can lead to false negative results. But other than that, there's not really much of a difference between the two assays.
Thank you. There's another question for you. When we're suspecting an adrenal tumor, in what time we should follow up the diagnostic trial?
So not sure what they mean by diagnostic trial. So I assume they refer to the endocrine workup. So what we do is that as soon as the tumor is picked up, then we do we immediately refer them for adrenal workup, so for the biochemical testing. The big difference is how concerned are you that this might be malignant. So if I have a young patient or a patient with a tumor that is above 4 centimeters, then I book them for an urgent endocrine workup. So within ideally 2 weeks of referral. However, if I'm not concerned about malignancy, I just want to rule out MAX or primary aldosteronism, then I can be more liberal, and usually we do the tests within 1 to 2 months.
Thank you very much. There is no more questions left. So thank you for your participation, Miriam and Alessandro, and for the audience, for the questions. Oh, I have one question for Miriam. Is there any time frame, duration, or number hours to achieve the competency framework?
I think this it depends upon, we would say probably hopefully within 2 years after you've done your mapping of learning needs. Of course, this needs to be discussed as a learning contract. So you need to have a learning contract with your manager, with your line manager, with regards to what is a time frame that you need to study with, or to complete the competency. By doing that, if you've got a learning contract, then you will have a specific time frame of how to achieve this competency, and it will not be long and winding to complete it. So
I think Miriam had again problems.
If you want the competency
okay.
when the time to do it, then why not? But I think I might. Okay, apologies. I'll type my answer.
Okay. So I have one question left, but I'm not sure it's for Alessandra or for Miriam. What amount of time do you have dedicated to study audit in your job plans? Any recommendations? I think it's for Miriam, but I'm not sure. For Miriam, yes.
I can hear it. I'm trying to type my answer. I think Debbie,
Okay.
thank you very much for your thank you very
Okay.
much for your question. I think this is still a negotiation with your manager again, on how much time they can provide for you to study. But I think as nurses, we are allocated time to study or to attend conferences or meetings, and that is we are being given study days. And I think depending upon within your trust, or within your team, how easy or how difficult it is for them to be setting you depending upon the need for the service. Because of course, if for example, if you're on your own, it might be difficult to be sent for training. But of course, that would be unfair if you're not being sent for training. So this should be part of your appraisal. Okay, this needs to be identified in your performance development review, as well as looking at your learning contract with your manager when you're doing your clinical supervision.
Thank you, Miriam. So thank you, all of you. Um, so we have no questions anymore, I think. So is there any questions from you, Alessandro or Miriam?
No, maybe just a comment on some of the points that Miriam highlighted, which I think it really shows the importance of working in a team, which is really key in adrenal tumor care. So not only as part of a multidisciplinary team, MDT, but also like working with your peers, your colleagues, your support staff, because that's really the only way to deliver excellent care to patients who have very complex medical needs.
So thank you again, all of us. I hope we see you again, all the audience, next webinar on 20th November. Thank you very much and good evening.
Thank you.
Thank you.